So what we want, of course, is for all the wounds we treat to heal up as quickly as possible with good functional and cosmetic results and without complications. That's what we want. But there are local factors that can interfere with wound healing. So what are the local factors that can adversely affect wound healing? Well, perhaps the most obvious one is infection. An infection means that there are microorganisms growing in the wound which give rise to the features of inflammation. And infected wounds will never heal. They can become chronic and go on basically indefinitely. Because what's happening is bacteria are going to release toxins, and those toxins will cause ongoing damage to the tissues, and wound healing won't be able to take place because the tissues are constantly being insulted by the presence of the infection. So for wound healing to be facilitated, we need to get rid of the infection. So we can use good localized wound cleaning treatments to try and get the wound clean, with good local wound management, with irrigations or whatever it is to try and get the wound nice and clean. We can also culture exudates from the wound or take culture swabs from the wound and try and work out what is the infecting particular pathogenic microorganism, and we can give systemic antibiotics. And when a wound is badly infected, then very often, in most cases, the patient will need systemic antibiotics to clean the wound up, to get rid of the infection, so the wound can start healing. So infection, looking out for the signs of infection, treating it should it arise. Now another factor can be local pressure on a wound, because if there's pressure, it doesn't take a lot of pressure to close off the capillary circulation, reducing the blood supply to the wound. So a wound needs a good blood supply to heal, to bring oxygen, to bring nutrients that are going to allow the healing of the tissues. We need a good blood supply, and pressure can reduce the blood supply. For example, even a dressing that's put on too tightly can adversely affect wound healing by interfering with the blood supply. And another thing wounds don't like is they don't like shearing forces. So if we've got two edges of a wound there, they don't like being sheared. We don't want there to be forces over the wound edges. So we need to have the wound edges approximated, certainly of its primary intent, but we don't want shearing forces. We want there to be no forces over the healing wound edges. So local pressure or shearing forces adversely affect wound healing. Now another one is the presence of necrotic tissue. So when there's a trauma, some of the tissue cells are going to be killed. Yes, we know that neutrophils and phagocytes can get rid of a lot of the monocytes that become macrophages. The big phagocytic cells can get rid of a lot of that dead tissue. But sometimes we can have necrotic tissue left in a wound. Over the surface of a burn, for example, there can be necrotic skin. Now this is bad for several reasons. Firstly, the necrotic tissue acts as a habitat. It's a nice place for bacteria to live. And as well as being a nice place for bacteria to live, the bacteria can eat it. So it forms a food supply for the bacteria, and that makes infection very likely. As well as that, living cells need to migrate over living cells. So to heal the wound by regeneration, we need migration of living cells. And living cells can only migrate over other living cells. They won't migrate over necrotic dead tissue. So it prevents cellular migration. So necrotic tissue should be removed wherever possible. And actually in the classification of necrotic tissue we could include pus, because if there's pus about we should let it out once it's consolidated, of course. We don't want to let it out at too early a stage. But there again, we don't want to leave it for too long either, because it can track. The infection can move down into deeper tissues and cause all sorts of problems. So the principle here is that there should be wound debridement. Debriding a wound means to take out the necrotic tissue, physically taking out dead bits of the wound. As long as we can do that atraumatically without damaging healthy tissues, and of course without causing too much pain to the patient. But sometimes in severe wounds like burns, we'll anaesthetise the patient and actually scrub off or get rid of all this necrotic tissue, take it down to healthy bleeding tissue, and then you can use good wound healing dressing techniques, or you can use a delayed primary closure and skin graft that wound. But you need to get rid of the necrotic material first. Necrotic tissue is an adverse factor in wound healing. And so is foreign bodies, foreign material. And the reasons are fairly similar actually. If there's a foreign body in a wound, it's likely to be associated with an infection. And it's also going to mean that living cells aren't going to migrate over the foreign tissue. So obviously if there's a splinter in a wound, we're going to take it out. We want to get rid of foreign material that's in a wound. So examining the wound for pieces of glass or other debris that might be in the wound and get rid of it, physically take it out, wash it out, don't really care too much, just get rid of it and leave viable, healthy tissue in the wound, and the body can heal once we've left it nice and clean. The nature of the wound is another factor. In high energy wounds, for example, road traffic accidents, falls, military injuries, there can be a lot of forces going into the tissues, and this can disrupt the blood supply. And if the local blood supply is disrupted, that's going to adversely affect healing. Or if a wound is very untidy and ragged and there's a lot of little bits of tissue flaps and things, again, there's lots of places for bacteria to hide, lots of places for foreign bodies to hide, promoting the risk of infection. So some wounds are intrinsically going to be more difficult for you to heal up than others. And another one that we have a lot of control over is cooling of the wound. Now, when someone just sustains an injury, for example, if someone sustains a limb injury, then very often it is good to keep that limb cold because that will promote vasoconstriction and help with the bleeding. Now, having said that, we don't want the whole patient to get cold because we know if patients are hypothermic, that's going to cause coagulopathy. So with traumatized bleeding patients, it's very important to keep the whole body warm so that the blood's at 37 degrees centigrade, because that's the temperature at which blood clots best. It clots best at physiological temperatures. If the patient becomes hypothermic, even by a degree, then presumably that's going to reduce the efficiency with which the blood clots. And if they're hypothermic by a couple of degrees, then certainly that's going to reduce the efficiency of blood clotting. But the actual bleeding area itself can be kept cool because we can get this vasoconstricting effect. But after that, once we've established hemostasis, it's very important to keep the wound at physiological temperatures. We want to keep it warm, because all of the activity inside cells depends on the functioning of the enzymes. Enzymes are going to facilitate all the anabolic reactions required to heal up the injury. So we need these enzymes to work to facilitate the biochemistry, and enzymes are very temperature specific. They only like working at about 37 degrees centigrade. They certainly don't like being cooler than that. So if you treat a wound, if you dress a wound once a day and that wound gets cold when you are dressing it, then that is going to reduce the rate at which that wound will heal, because cooling of the wound is another adverse factor in wound healing. So there are just a few local factors that can adversely affect wound healing that we can think about, and for most part we can compensate for.